All right, in this one, we're going to talk about yellow nail syndrome. This will be a relatively quick one. This was from my Zebra Saturday lecture series. So we'll go through it. We'll talk about yellow nail syndrome and Meigs syndrome. I've actually seen questions on Meigs syndrome, so that'll be a little more high yield for USMLE. But I like doing these Zebra Saturdays so I can just teach you about some of these more rare diseases that are pretty cool to learn about. So we'll do how to spot yellow nail syndrome, what's the pathophys, what's the management, how to spot Meigs syndrome, pathophys management, and then we'll do a putting it all together. So this was our case to consider. We have a 66-year-old woman. She presents with gradually worsening shortness of breath, persistent cough, swelling in her legs over the past 6 months. She also reports chronic postnasal drip and frequent sinus congestion. She denies fever, hemoptysis, or weight loss. Her past medical history is unremarkable and she takes no medications. On physical exam, she has decreased breath sounds and dullness to percussion at the bilateral lung bases. Her fingernails are thickened and have a gold hue with increased transverse curvature and a lack of cuticle. There is 2 plus pitting edema in both lower extremities. Chest imaging reveals moderate bilateral pleural effusions. Thoracentesis yields a straw-colored exudative fluid with lymphocytic predominance and negative cytology. A sinus CT shows diffuse mucosal thickening consistent with chronic sinusitis. No masses or lymphadenopathy are noted on imaging. Which of the following is the most likely diagnosis? Is this diffuse systemic sclerosis, yellow nail syndrome, tuberculosis pleuritis, or Meigs syndrome? So take a second and consider. Obviously, it's probably going to be either yellow nail syndrome or Meigs syndrome because that's what we're talking about today. But take a second, think about it, and then we'll discuss. So this would be yellow nail syndrome. And again, obviously you knew probably coming in it was going to be yellow nail syndrome. But I think rereading the vignette and actually going through step by step, okay, why is this yellow nail syndrome is actually very helpful. It's helpful to see the presentation over and over again. Yellow nail syndrome, it's a relatively rare disease. It's got this clinical triad of nail findings. So we see these thickened yellow nails with increased transverse cuticle and or curvature and absent cuticle. We see lymphedema, so usually bilateral lower extremity pitting, or it could be non-pitting edema, and then some sort of respiratory involvement. Maybe they have chronic sinusitis, postnatal drip, exudative lymphocytic predominant pleural effusions. One of them, both of them, all of them, it doesn't really matter, right? So we're going to see the nail findings, this yellow nail, obviously, lymphedema, and then some sort of respiratory involvement, either upper or lower or both. All right. So again, it's a rare syndrome of unclear etiology seen in older adults. The diagnosis is clinical based on that triad. The pleural effusion, right, we'll do a thoracentesis and it'll be exudative. And I'm going to leave how we define exudative for the end because that's my putting it all together case. It'll be a lymphocytic predominant negative cytology. So when it's lymphocyte predominant, that tells me that it's been a chronic cause, right? If it's neutrophilic predominant, that's more of an acute cause. And then we must exclude the mimics, right? So we need to rule out malignancy, TB, or connective tissue disease. So why isn't this the other options I gave you? Well, she doesn't have Raynaud's, sclerodactyl, or autoimmunity. Nothing was really pointing me towards sclerosis. For TB, there's no fever, night sweats, risk factors, or TB exposure. TB can cause a lymphocytic exudative pleural effusion, but she really does not fit the clinical picture of TB in this case. And then Meigs syndrome, right? We're going to talk about Meigs syndrome, but that requires an ovarian tumor and ascites, and it's not present here, right? So that leaves us with yellow nail syndrome. So let's dive a little bit deeper into yellow nail syndrome. It's a classic triad, again, of the yellow thickened nails, lymphedema, and respiratory disease, so effusion, sinusitis, things like that. The underlying mechanism, it's likely due to an acquired lymphatic dysfunction, right? They're not fully appreciate the pathophys yet, but they do know that there's an acquired lymphatic dysfunction that is likely leading to this clinical triad. There's an emerging link to this WNT planar cell polarity signaling defects. Okay, so we're thinking lymphatic dysfunction and now a genetic mutation, this WNT planar cell polarity signaling defects. The impaired lymph drainage will affect your nails, your lungs, and your extremities, right? The lymph is really important to grab in all this extra protein. If we can't grab in all that extra protein and gunk from my interstitial space, it builds up. That increases the interstitial oncotic pressure, which will pull fluid out of the vasculature. So remember, we have oncotic pressure in my vasculature, mainly driven by albumin, and we have oncotic pressure in my interstitial space, right? Whichever oncotic pressure is higher is going to draw more fluid in, right? So if the oncotic pressure is higher in the interstitium because the lymph isn't working and we've got all these extra proteins sitting around, fluid's going to leak out of the vessels into the interstitium, and that's how we can get these exudative effusions. Okay, that's also right. We have lymphedema because of the underlying lymph malfunction. That's how we can get lymphedema in this case, right? Because the lymph is obstructed, so it's not, the fluid's not able to move down as well, and so we can get very leaky vessels and increase hydrostatic pressure in the lymph, and then the fluid can leak out that way as well. So that's how we get the lymphedema and the exudative pleural effusions. And of course, we have lymph nodes in my nails too, and so obstructed nail or obstructive lymphatic system in my nails can lead to that yellowing of the nails due to probably underlying fungal infections and some sort of other damage to my nail beds themselves. So again, management is going to be symptom directed for the pleural effusions. We'll do recurrent thoracentesis. We can do pleurodesis or surgical decortication if it's refractory. For the respiratory manifestations, if they have chronic sinusitis and bronchiectasis, we can use long-term macrolides. They have anti-inflammatory and potentially some nail improvement. The lymphedema, we're going to do compression therapy, manual drainage, and skin care. For the nail changes, some literature states vitamin E at 1,000 to 1,200 milligrams per day, plus or minus fluconazole, has been helpful. There's variable response, and some may improve spontaneously. Okay, there's really no curative therapy, so we're going to tailor the treatment to the clinical severity of these patients. Um, I really kind of talked about this, but I wanted to just harp on why is this an exudative effusion? Okay, so the pathophysiology of yellow nail syndrome, its lymphatic dysfunction is central to the pathophys. We get impaired fluid resorption. This leads to increased microvascular permeability, and the protein-rich fluid is going to leak out into the pleural space. All right, exudative pleural effusion we're going to talk about more, but we're going to see more of this high protein content. In this case, in yellow nail syndrome, it's lymphocytic predominant, and then negative cytology, which points me away from a malignant effusion. Again, transitive effusions can be caused by hydrostatic or oncotic imbalances, and that's not seen in yellow nail syndrome. So the key point, based on Light's criteria, which we'll talk about in a little bit, the underlying impaired lymphatic destruction that drives the pathophys of yellow nail syndrome leads to really leaky lymph vessels, which allows protein to leak out, and we're by definition we're going to satisfy Light's criteria, which again is coming up in a second, and then we're going to be defined as an exudative effusion. All right, here's a picture of what the yellow nail syndrome nails may look like. Again, we can see it on all 10 fingers and all 10 toes too. So we get the yellow nails, increased curvature, and an absent cuticle, our classic. All right, let's quickly talk about Meigs syndrome. So Meigs syndrome is also a classical triad. We have a benign ovarian tumor. It's typically a fibroma. We have ascites, and we have pleural effusions that are usually right-sided, but they can be bilateral. So usually you'll see resolution of the ascites and effusion after the tumor is resected. And obviously resecting the tumor is going to give us our diagnosis if we see the fibroma. What's the pathophysiology? These tumors can produce peritoneal fluid, which moves out into the peritoneal space and can lead to ascites. That fluid can then migrate to the pleural space via diaphragmatic and lymphatic defects, right? Almost everyone, it's actually relatively normal for the diaphragm to have small little holes in it. So extra fluid in the peritoneal space can translocate through those defects in the diaphragm. Okay, there's something called hepatic hydrothorax, which is classic in a patient who has cirrhosis, who has ascites, right? They have these massive ascites, and that acidic fluid can move through the diaphragmatic defects, and those patients will classically have a right-sided pleural effusion. Okay, so most of these pleural effusions are exudative, again, due to a similar reason, due to lymphatic duct dysfunction in these patients. So again, the associated tumor is an ovarian fibroma, is the most common cause, but other tumors like a fibrothecoma or granulosa cell tumor are sometimes associated with Meigs syndrome. The CA-125 may be elevated, but it does not imply malignancy. The CA-125 is often just elevated due to peritoneal inflammation, right? And so we could have peritoneal inflammation secondary to the tumor or to this extra fluid in my peritoneal space, or it could be something completely different, right? So it doesn't necessarily imply malignancy. There's something called pseudo-Meigs syndrome, which is a similar triad of an ovarian tumor, ascites, and pleural effusion. But by definition, Meigs syndrome that ovarian tumor has to be a fibroma, right? We call it pseudo-Meigs syndrome if it's a similar presentation with a non-ovarian or metastatic tumor, okay? That's getting a little bit into the weeds, but I would remember Meigs syndrome, ovarian fibroma, ascites, and pleural effusion. It's the ascites and pleural effusion are due to this tumor that's secreting peritoneal fluid itself, and then that peritoneal fluid can translocate through diaphragmatic defects and the lymph defects. So if you want to read more, he has 3 different studies. The first 2 are on yellow nail syndrome. The last one is on Meigs syndrome. So if you want to read more on those, screenshot them and throw them into Google, and you can read them. And now let's put it all together, right? Like I promised, I want you to tell me what is Light's criteria. While you're thinking about this, I will do a whole lecture on my schema for pleural effusions. It's quite complicated. We can break it down very simply to make it a lot easier for us to understand. But you first tell me what Light's criteria is, and the pleural effusion lecture will be coming in the future. All right, so Light's criteria is how we differentiate an exudative versus transudative effusion, okay? So an effusion is defined as exudative if any of the following of these 3 are true, right? So I only need one of the following, right? If my protein in my pleural space is greater than 0.5 times the protein in the serum, exudative, okay? If my LDH in my pleural space is greater than 0.6 times the serum LDH, exudative. If my pleural fluid LDH is 2/3 the upper limit of normal serum LDH based on my laboratory analysis, exudative. Okay? Any one of those will satisfy it, right? So I don't need to calculate all of them. Any one of those, right? So let's say my serum protein is 8, which is relatively normal. And my pleural fluid is we do a thoracentesis and we see my pleural fluid has a pleural protein of 5. Okay, that's more than 0.5. By definition, it's exudative. Okay, um, that's all you have to do. You can do the same for LDH, and then that last bullet point. Let's say my LDH, my normal range of LDH based on my lab I'm using, the high end of normal, let's say, is 1,000. Okay, I'm just pulling a number, right? If the pleural fluid LDH that I take is, let's say, anywhere greater than 666, right? That would be 2/3. Let's say it's 800. That by definition is greater than 2/3 of the upper limit of normal of my serum LDH. So that's how we satisfy that 3rd criteria. Again, we only need one out of the 3. When I think about pleural effusion, just really quick, we can break it into transudate. So we're not satisfying any of these, or we have exudate. We're satisfying at least one of them, right? When I think about transudate, it could be due to increased hydrostatic pressure. It could be to abnormalities of the oncotic pressure, or it could be due to diaphragmatic defects. Okay, those are the 3 major buckets of transudate. And when I think about exudate, it could be due to infectious cause, or it could be due to non-infectious inflammatory type situations, right? So when I like in broad buckets, right? Transudative effusion will be due to likely increased hydrostatic pressure or some sort of abnormality in the oncotic pressure, right? Either it's increased interstitial oncotic pressure or decreased capillary oncotic pressure, or transudative could be due to diaphragmatic defects. And then when I think about exudative, the underlying pathophys is usually some sort of inflammation or cytokine response that is making my vessels leaky. So at the core of that pathophys is increased capillary permeability. However, we have to get there, right? In infections and malignancy, it's going to be due to the cytokine response making my vessels leaky. Things like collagen vascular diseases can cause my vessels to be leaky. Man, there's so many causes of the non-infectious pleural effusions. There's that I counted, there's about 14 major buckets that we have to consider. So that's going to be a very in-depth lecture. That'll be a lecture on its own. So in this lecture, we covered pathophys management presentation of yellow nail syndrome, pathophys management presentation of Meigs syndrome. We then discussed Light's criteria as a nice little preview of what's going to come in a future lecture on pleural effusion. Knowing Light's criteria off the top of your head, really important for exams, really important for board exams. Hopefully this was interesting with the yellow nail syndrome and Meigs syndrome, 2 very unique diseases. Reach out if you have any questions. Let me know what other topics you want me to cover. Until next time.